Um, Please introduce yourself in the chat. We'd love to hear and see who is here today and also what brought you here today. So if you could just add that to the chat. Also for today, we are doing it a little bit differently with a more of a Q&A type of format. So I would encourage people to add questions to the chat or ask questions live. We really have the time and the space to be able to have a much more interactive dialogue. So please feel free, and we encourage you to ask those questions and have a good discussion. So we'll get started in just a couple of minutes. But again, if you've just joined us, please do introduce yourself in the chat and we will get started shortly. I see lots of familiar names. Welcome back, and also some new ones. So for those who are joining for the first time, thanks so much for being here. And we'll go through sort of the format once we get started, once more people have joined here. Great. We've got someone here from Alabama, from Bakersfield, from California. So welcome, everyone. Thanks for letting us know you're here. Just quickly, while we're waiting for others to join, I'll go over this at the end as well. But for next month, for May, when you register for one of our community forums, it actually keeps you registered every month thereafter. So you'll use the same link to join the next time. For next month, because of the Memorial Day holiday falling on the last Monday of the month, which is usually when these community forums are, we are going to shift it a week earlier. So next month, our forum will be on May 20th, a week earlier, to accommodate the Memorial Day holiday. So we'll remind people again at the end and send reminders ahead of time as well, but just wanted to make that note as we're waiting for people to join. All right. And I see more people joining. We've got Oregon, Santa Rosa, California, Los Angeles, Nebraska. Great, welcome everyone. My fuzzy. Okay. Laura Esserman, who is our speaker today, should be joining momentarily. She just tried giving my phone a call, which probably means she was having trouble getting in. So she should be joining here momentarily, but I will go ahead and get started. Oh, there she is. We have a couple of conferences and things we'd love to tell you about as well. I can save that towards the end now that Laura is here, but yeah, again, welcome everyone to our April Community Forum. If you haven't yet introduced yourself in the chat, please do so. We would love to see who's here and also what brought you here today. And again, great to see so many returning faces and some new faces as well. So for today's session, we are intentionally creating this more as an interview or a dialogue. So we'd love to hear your questions. The general topic for today is around breast cancer and some of the information and probably news that you've seen about the incidence of breast cancer on the rise in younger women. And, you know, we'll focus on that plus a bunch of other information, and please ask questions that you find most interesting, whether it's on the topic or not. We do want to be able to have this be an open session where you can ask as many questions as you'd like. So you can either put your questions in the chat, you can raise your hand, or speak up during the discussion. We encourage you to do that as well. If you're not speaking, please do mute yourself. The meeting is being recorded, and that's so that we can share it with those that weren't able to join us. And then at the end, there will be a short survey feedback. So just bringing everyone together, the reason we've been doing these community forums really is to be able to have an open dialogue and to be able to share information that our team is aware of in terms of women's health and breast cancer, and really to be able to move together toward equity and better outcomes for everyone. So it's important that we're able to share and have a conversation and learn what's most important to our community, as well as to be able to share information back as well. So we have had over 2 years worth of forums to date. And so on our YouTube channel, we have all of them recorded, and I encourage you, there's a whole host of different topics that we've gone over. Some of them we revisit if they're topics that we know people are really interested in. And so do let us know if there's new topics that you don't see on here that you would like to hear about on future forums. Just very quickly, there are a couple upcoming events that we thought this group might be interested in. One is a group that we partner with called Facing Our Risk of Cancer Empowered, or FORCE. And they have their annual conference coming up in June. It's in Philadelphia. So if anyone is in that area, really it's to provide information and resources for those that have a personal or family history of cancer or a risk of hereditary cancer. This organization has wonderful, wonderful resources and just really great information. So if you would like more information, let us know. One other quick save the date for a conference coming up in November, which is called Rise Up, or Revolutionizing Investigations to Step Up Prevention for Breast Cancer. And it's here in San Francisco. So it's a brand new conference that's really trying to bring together a more interdisciplinary group of researchers, community members, patient advocates, and other organizations to have a conversation and really be able to think about reducing both breast cancer mortality and incidence, and think about breast cancer risk and just women's health across the lifespan as well. So we'll keep this on people's radar, but this is one in San Francisco that if you're local or you want to travel in, we'd encourage you to do so. All right, so with that, I will introduce Laura Esserman, who is our overall principal investigator and leader of the Wisdom Study. She needs really no introduction, but she is here today to have sort of a Q&A interview style discussion around breast cancer in younger women. And there's been a lot of news recently about the rise of incidence of breast cancer in younger women. And so we'll talk a little bit through some of the questions we frequently get to be able to understand a little bit more about maybe if there's understanding of why this is happening or what we can do about it. And in particular, how we can try and bring wisdom to more people to be able to give a comprehensive risk assessment and help those people at highest risk to be able to take action at a younger age. So with that, I will say hello to Laura and welcome. I think you're on mute if you can hear us. Almost.
So I am on mute. How about that? I'm actually just trying to switch over to my computer, which I'm not sure why that is not working. Looks like, but I'll start here until it, I don't know why that's not working, but I will. It's like can't be reached. How is that? Okay. Anyway, well, thanks so much, everybody. So glad everyone's attending. And I think what I'd like to do is start out with, I'd like to start by saying, let's talk about, the Olivia Munn story and why that's important and why I think that's like an opportunity, because I think that what we know is that Olivia Munn went to her physician, who used actually something that is an old risk model, the Gale model, and we'll talk about that in a minute. And they figured that her lifetime risk was pretty high, maybe 35% or 30%, enough to say, wow, let's put you in, let's screen differently. Let's think about doing this differently. And in fact, they ordered an MRI and they found cancer. Now, I don't know anything more about it because, that kind of detail is not provided. But I think what it tells us is that, it tells us that there's more to be done by looking at people's risk rather than, the way we screen. The whole reason the wisdom study exists is because we screen as if everybody is at risk for the same cancer, and that there's only one kind of cancer, and that everyone's risk factors are the same. Of course, we know that that is not true, right? We know that there's different kinds of cancer. We know that people have different kinds of, we know that there are different kinds of treatments for different kinds of cancers. We don't treat all cancers the same anymore. We just don't do that, right? So let's see if this is connecting. I don't know why it's wrong. How my computer is not being very friendly today. So I'll just use my phone. Oh no, here it goes. Let me just switch over. Once again.
Yeah.
So as Laura's doing that again, if you are just listening in, please make sure that you're on mute so that others can hear. And Laura should be joining back in momentarily.
Now I'm on.
Okay, perfect. We'll spotlight you again so that people can see you. There we go.
Okay. So, so what does this mean? What does it mean that people are looking at risk models? So the model that was used for Olivia Munn was the Gale risk. And the Gale risk is something that's been around for a long time. In fact, it was designed on a cohort of women, 300,000 women, in fact, who were followed in the Cincinnati area for years. And this was actually even started before there was, screening. So it had the usual things of, when was the birth of your first child? When was, how old were you when you had your periods? Do you have a family history? And in fact, that's really where at that time, we really thought that it all came through the mom. And, but it turns out, of course, that it doesn't just come through your mother. It could be from your mother or your father, right? And so, so these, and it also was looking at breast biopsy. And again, this was breast biopsy not driven by a mammogram, not by a mammographic abnormality, but by something that you could feel, a palpable abnormality. And so that tool, actually, where it was best was trying to figure out who's the highest risk versus the lowest risk. So it wasn't, we used this as a cutoff for the first big prevention trial that the National Surgical Adjuvant program did. The NSABP did this program called a prevention trial called PO1. They use a cutoff of 1.65 and for the Gale risk, and then if people were in the higher risk, they were randomized to tamoxifen versus not. It was like 13,000 women, and this is sort of when our first trial showing that tamoxifen worked to reduce breast cancer risk. And but it turns out that that 1.65 number is not particularly useful. You know, if you're young and have a big family history, or you know, your lifetime risk could be quite high, but your 5-year risk, you know, might be something like 0.8, so not terribly helpful. So that's one of the reasons why we started thinking about, well, what is your short-term 5-year risk, and what is your lifetime risk? So how would we think about that? So that's what this Gale risk tool was used for, and we used it, and we actually found ultimately that we thought we should focus on the people in the top 2.5% of risk, because that very highest risk group are the people we thought would benefit most from taking some kind, you know, some kind of preventive intervention, like taking a statin if you have heart disease risk, or you have a history of stroke and heart attacks, or or your cholesterol is high. So those are the kinds of things that people learn that allow them to say, oh, okay, these are things that we can do. And, you know, especially now that we have things like baby tamoxifen, which is like a quarter of the dose of tamoxifen, and it's been shown, you know, with DCIS that it works just the same, and it's so much better tolerated. There's a couple, 2 or 3 studies showing that. So again, we probably don't need something quite so much, and a lot of people are afraid to take a medicine like tamoxifen, but especially that really small dose of tamoxifen for young women, you know, has an impact that continues to increase for 5 or 10 years. So that is all sort of part of this background, thinking about, well, wait a minute, what if you're at risk for a fast-growing or hormone-negative tumor? Is tamoxifen going to help you? Well, probably not. And what if you were at risk for this kind of slow-growing tumor? Would tamoxifen help? Well, it very well might. And it's always one of those things that's like, well, you don't have to take it, but what if you were to take it and it didn't bother you at all? And if when you're young, your side effects are extremely low and there's nothing permanent that you would get, why would you not want to do that? So that's sort of what got us into this idea of saying, well, you know, we have to do a whole lot better understanding what risk is. So we use a much more updated model called the Breast Cancer Surveillance Consortium model, that's based on 1 million women in the United States and a much more diverse population. And that's really helped us. But over time, that model has also improved, looking at body weight, looking, you know, at a number of other factors that could be important. And these are all helpful, just as it's just common sense, right? That before you start thinking about screening and prevention, the first thing you have to think about is risk. What is your risk? And if you've got a high risk for what? Are you at risk for a hormone-driven cancer? Are you at risk for a hormone-negative cancer or a fast-growing tumor? And there's different things that we can do. We're starting to understand what treats, you know, some of these hormone-negative tumors are what we call immune-driven. And there, what you eat could really make a difference. Probably one of the most important things we can do to reduce the risk of hormone-negative tumors is really having high fiber diets. You know, the average American eats about 15 grams of fiber a day when we should be really getting in like 40. And why does that matter? Because it matters, what you eat really determines what these colonies of bacteria are in your gut, because what, you know, how you break down the food. So the output of breaking down the first one determines what the next colony is, and so on. And some of these really make a difference in your immune health. So that's really exciting, because those are fairly easy things to do. You know, box of raspberries is 8 grams of fiber. An avocado has 10 grams of fiber. You know, a tablespoon of chia seeds has like 15 grams of fiber. Nice and crunchy, you can sprinkle on it everything, from yogurt to soup to everything. So, you know, if someone has, you know, is at risk and is at higher weight, and particularly at risk for hormone-negative tumors, these are the things, you know, really getting a coach trying to work on weight reduction and exercise could make a big difference. And, you know, maybe that's something that we can also think about, all these new GLP-1 drugs that really
impact your safety. Remember, we had Walter Willett was our guest in December, and he showed how for hormone negative tumors, or the so-called triple negative cancers, that if you ate green leafy vegetables and the kinds of fruits and vegetables and sweet potatoes, etc., these there was like a huge drop in the hazard rate, not for the hormone positive, but for the hormone negative. And I always used to say, wow, if that was a drug, if there was a drug for that, that would be approved and everyone would be using it. Ironically, now there is, that's these Wegovy and, Ozempic and the so-called GLP-1 metabolism altering drugs. I think it's going to be very interesting to see how these play out and sort of changing what we eat and what we do and sort of improving our health. One of the nutritionists and chefs that I used to work with used to say, if you want to know if you're eating something, if you're eating the colors of the rainbow, probably what you're doing is the right thing. So anyway, this was, what I was really glad to see someone like Olivia Munn's story, because it highlights that the first and most important thing you should do is think about what's my risk and what's my risk for a fast growing, slow growing tumor. And then based on that, I should think first about prevention and second about screening. And screening can be, when do I start? How often do I do it? What modality should I use? What about how dense is my breast tissue? And so we at Wisdom, in the Wisdom study, are really trying to put all this together and help study this carefully so we can make, really provide some really good recommendations for all of you. And, there was a follow-up study to Olivia Munn. Is now Myriad Genetics is offering a test that costs a couple $1,000s, which is using the Tyrer-Cuzick model. That's another model. It gives more, counts family history a little bit higher in breast density, and then adds in some genetic tests, but they're not very transparent about what it is, and it costs a lot of money. The Wisdom study does all of this, and it's free, and we're tracking everybody so that we can make better recommendations. So everyone who's participating is creating the future by informing the future. And I think that's the way it should be till we really get it all straightened out. And the other thing that we do that I think is really important is we're trying to look at the individual genes that make up people's background. That is, if you're Asian or you're Latina or you're African American or you're white, that we can adjust how we look at the genes that you inherit to understand how that might impact your risk, so we can tailor it more to you. And hopefully we'll be able to add in some of these cool new algorithms for looking at breast density using mammographic AI, or so the advanced algorithms to really, not artificial, I mean, they call it artificial intelligence, but it really is putting this, it's machine learning really, to try and figure out how to do a better job of stratifying risk. So I'm going to stop. That's my preamble.
Yeah, one of the questions that we usually get in talking about, a rise of breast cancer incidence, particularly in younger women, is, well, why don't we just screen everyone earlier? Why don't we move the guidelines down to 35 or 30? And so maybe if you could you've alluded to some of the answers there, but just explain the answer to that question, why moving the age down maybe isn't going to help that incidence rate.
Sure. So screening isn't completely harmless. I think that there are a range of, and screening isn't really necessarily that effective for all the types of tumors that we want to find. For example, I run a big trial called the I-SPY trial, where these are the high risk patients at risk for who have fast growing tumors, and we're looking at that. So 85% of these women don't have a screen detected cancer because the tumors either grow too fast, or they're in women who are younger than the average age that we start screening. So we're not doing, even with the screening we have, we're not doing that great a job. And the younger you are, the more dense your breast tissue and the less effective mammography is. And you can say, okay, well, why don't we just do an MRI on everybody? Well, MRIs have a pretty high false positive rate, could be 40% in the public. And, they're also very expensive. And MRIs right now are not covered and considered to be part of the screening package. And you could have copays that are really high, $1,000, $2,000. And, if you look in aggregate for screening, even with the changes the American College of Radiologists is recommending, we're screening everybody at 40 and screening people with BI-RADS C and D density with MRI, this would cost somewhere in the range of $35 to $40 billion a year. What we're recommending by tailoring it based on risk would be closer to $8 billion, which is about what it is now. That's what the screening recommendations are now. And the thing is, you want to do more for the people that need it and less for the people that don't. So what are the kinds of costs? You can get a callback. The callback rates in this country are 8 to 10% for your first screen. Of all the things that are recommended for biopsy, 75% are nothing. When you're called back and told that you have to have a biopsy, it's very frightening. Once people have had 2 or 3 of these callbacks and scares, half of them stop coming back for screening because it's very upsetting and it's really uncomfortable. So I think, and we're still is, I think, finding ductal carcinoma in situ. We call that a cancer and we treat it as if it's a cancer when in fact it's not. It's not life-threatening. And it's, I think, more of an opportunity for prevention. But we don't give people an opportunity to test that. So end up getting a bilateral mastectomy that they probably didn't have to have, but were frightened into it. Or when people find all these things wrong, I had someone the other day, sorry, who'd come in who had had 9 biopsies. She was 42. And was basically said, that's it, I'm never screening again. That's like every time she came in, because you're finding all these things. So when you're younger, you can find calcifications and find these things. So we have just got to do better. And this is where I feel like we can do risk assessment early on. And we can do that at 30 because the genes you inherit are the genes you inherit. I mean, why are we not just finding, even though carrying a mutation is not common, maybe it's 2% of the population, it puts you at an 80% risk for developing cancer. Why aren't we at least finding all those people? And then it turns out that there's hundreds of other genes that you inherit that by themselves don't mean anything, but together, poly, many, genic, gene, risk, can really identify people who are at much higher risk for cancer and for what type. Now there's ways in which we can use that information to start to understand who's at risk for these fast-growing tumors, where we can get an MRI. We're working with my colleague, Dr. Olapade in Chicago, where you can say if you have one of these, you can be screened with an MRI or some kind of contrast-based imaging exam every 6 months. So I think screening, we'd like to make screening really simple and easy, but it's not, it's complicated. And I think we want to use it wisely and well. Linda,
Yeah,
you have a question.
yeah.
Yeah.
My question? I had a question about male breast cancer because I just did my questionnaire because I'm in my 7th year with the Wisdom Study. And
Thank you.
you're welcome, but you don't ask any questions about men in the family. It's like all female. I'm looking at the thing real quick. Like you ask, I'm sorry, I should have been more prepared.
No, we
But
should
you ask,
look at that.
you ask like
Make
number
sure
of
it's really-
sisters, numbers of daughters, maternal aunts. Will you ever
should
ask
ask-
about the males in the family, I guess is what my question is.
Well, we should ask. You're right. We should
We
ask.
We have one question about history of male diagnosis of male breast cancer in the family, but we don't go through the more detailed which
Mhm.
relatives, and that's something that we would like to change, especially as we're upgrading our risk models to be more comprehensive. Yeah.
I mean, I feel like some people don't understand that, like if they're, I mean, people don't realize too, if a female has breast cancer in the family, a male could too. So, and it's not always genetic. I mean, my husband died from metastatic male breast cancer. So I feel like it's important to keep, and all, you know, all male and female
You're
in conversation.
100% correct. And
So thank you.
half of the mutations come from the father's side. And sometimes that's why it's hard to find, because if you've got a lot of men in the family, even if you have a BRCA mutation, your risk of breast cancer is about 8%. So it's about tenfold less in
But
men.
can I
So it's
ask,
about 80% in women and 10%, 8 to 10% in men.
I just wanted to add, I know a few women, and that's how they found out they had a mutation, is because someone in the family that was a male was diagnosed with breast cancer, which led to genetic testing, which led to them knowing. So I just think it's important.
Well, absolutely. But this is why, and actually it turns out that in wisdom, the first cohort of wisdom patients, 60% of women who had a mutation did not have family history.
Mhm.
And so that made us ask, well, first of all, that's partly because to join wisdom, you had to be at least 40 and you couldn't have had any history of breast cancer. So we're missing the people who had breast cancer at an early age. And so that might be people who have the higher family histories. But,
Mhm.
you know, it's just not that good a screen. The best way is just to look at the genes and sequence them. We can do it. You know, Myriad does it for $2,000. Color does it for $250, and so that's who we're using.
Mhm.
It's just as high quality data, and this is something that's affordable. But that made us say, well, gee, why don't we start looking at 30?
Mhm.
So we lowered the screening age to 30, and so why not let everyone get the genetic test starting at 30? And we use, what we're doing is we're getting a low pass of all of the genes, so that as the field improves and changes, we're able to get in, we're able to get in the, we're able to make changes and adapt um, our ways of doing risk assessment. But we should ask about that. But we now are no longer, so there's two important things that we're doing in the wisdom study. We are not randomizing to annual versus the personalized arm. We're just letting everybody choose. And we assume that about 90% of people are choosing the personalized arm. So everybody can get this personalized testing. We've lowered the screening age to 30. We have better tools that we are using to try and understand risk. And we have sort of updated our breast health decisions, which is our prevention platform. And so that's starting, so we're starting to accrue the next 50,000 women. And we want to see if these new tools that we are developing are really do what we think they're going to do. Are we picking out the people with the high risk for the fast growing cancers? To me, that's such an important opportunity that's just missed by the way
So
today.
one thing you just mentioned, Laura, was that we lowered the screening age to 30. And I just want to make sure it's clear. We've lowered the age to join wisdom to 30. So you can get that comprehensive risk assessment. And then from there, if we identify people at really high risk, we can tell them to consider screening and, more importantly, prevention at a younger age. So it's not that we'd start screening at 30, it's that we would offer the risk assessment.
Right.
Yeah.
We're assessing at 30.
Assessing, yes. So one of the things that you sort of hit upon, but one of the other topics that I think can be confusing is if you are identified as having an elevated risk, but maybe that risk isn't quite high enough to start screening, doing mammography or MRIs in your 30s, but you still have an elevated risk, we'll recommend considering prevention and risk-reducing medications. You mentioned tamoxifen. So one of the questions that we often get is, if I'm at risk, why wouldn't I start screening? Why should I be taking prevention medications? What's the long term, and why one and not the other?
So that's a great question. And I think it became really confusing. Well, why would you think about doing something that's preventive rather than just screen? Maybe so the way we think about what does a medication like tamoxifen do? This is a selective estrogen receptor modifier. And when you take it, it sort of slows down the rate of cell turnover in the breast, which can be very active. And we do know that, like on an MRI, if you have a lot of um, uh, if you have a lot of what we call background enhancement, and that's probably because the tissue's busy. It's busy turning over and doing things. We know that puts you at higher risk. And so what tamoxifen does, it just kind of shuts some of that down. And that benefit you accrue continues to increase over 10 years and over a lifetime. So the time that you want to do that is as early as you can when your risks are very, very low. It doesn't change your fertility. It doesn't change, any of these things, and it doesn't, change your risk of ovarian cancer or endometrial cancer, because when you're young, it makes very little impact on other health-related risks. And a low dose could make a really big difference, and this is something we can follow on MRI. But your risk on an annual basis may not be enough to start screening, but by the time you start screening, you've now lowered your risk substantially. Prevention is going to beat early detection every time. And I always tell people, if I identify that they really are someone that's worth thinking about, that they have a lot of risk, I said, look, don't make a decision, just try it for a month. And if there isn't anything irreversible from that, just try it for a month. And, if it doesn't bother you and it's no worse than going home and putting a piece of paper over your head, and, if you do this for 5 minutes, and I said that would cut your breast cancer risk in half, I bet a bunch of people would do it if it was true. So maybe taking tamoxifen is no worse than that. But the only way is if you try it yourself.
And how much does it reduce your risk?
Cuts it in half. So, if you had a lifetime risk of 25 or 30, you would be down to 12 or 15%. So it would be like 1 in 3 down to like 1 in 6. That's a big impact. And part of what we're trying to do in this Rise Up meeting is try and get people to really think in a forward way. We're doing all this stuff, manipulating cycle control. We have cycle control, birth control, postpartum weaning, IVF, postmenopausal hormone replacement. Why aren't we formulating these drugs so that they are actually reducing your risk? 65% of women take oral contraceptives at some point. What if they dropped your risk of breast cancer in half? I think there's many benefits to that. One is that we would finally start to see a drop in the incidence of breast cancer. And second, you can market these agents as breast cancer prevention agents with a black box warning not to get pregnant. And then they'd stay on the market, just in case. We need that protection.
So for
Anyway,
those, yes.
Yeah, I just think it's a real opportunity. And so we're trying to inspire people to think about new ways of formulating these agents so that we can maybe think about getting those kinds of things on the market so that people really show up with much less risk.
So if someone doesn't meet the criteria for considering risk reducing medications, you talked about diet and fiber. Are there other things that people can be doing? And if you're not screening, other things you should be aware of in terms of your body and changes and things like that?
And well, it turns out most of the things that are good for you, in general also reduce the risk of breast cancer. So eating, a healthy diet, less meat-based, more plant-based, much higher in fiber, exercising more, these are good. And I would say, fortunately, no one has implicated caffeine, so that's good. No one has to give up their lattes. But one thing that people really have to think about is drinking. There is an increase in the incidence of cancer in young women. And when this happened in Marin, one of the culprits was the amount of white wine that women were drinking. And, we see that there's increased, alcohol consumption. There's absolutely no question that alcohol is a risk factor for breast cancer. It's been shown for the last decade or couple of decades, and it's one of the most consistent risk factors and things that people see. I always like to say, if you want to drink, find a night at the most 2 where you have alcohol, and otherwise, have a soda water with an umbrella in it, make it festive, or mix juices with it. But alcohol is a big culprit, is definitely a big culprit.
And someone earlier had asked, since alcohol seems to increase the incidence, which you just said it does, what are some ways to encourage younger women to decrease their alcohol consumption? And I think talking about breast cancer is probably not as common at younger ages. And one of the things we're trying to do in Wisdom is to make people aware that if you know your risk, if you can do a risk assessment, joining Wisdom, these are the risk factors. These are the things you can do to lower your risk. But yeah, I think if there was more knowledge around the connection between breast cancer and alcohol consumption, perhaps that conversation can happen earlier on. So yeah, and that was, as Laura mentioned, one of our community forums in December. So happy to send that link around to people as well. It was a good one with Walter Willett, who's at Harvard, I believe.
Yes.
Laura, one other question, and I sort of asked this as a 2-part. So the second part of it is, even if you're not recommended to screen, or even if you do get regular screening and you had a mammogram 2 months ago and you notice something different, regardless of that regular normal mammogram, what should you do? And what are some of the things to look out for?
So having a normal mammogram is not a guarantee that nothing is wrong. If you feel a mass and it's new, you have to have someone check it out. Likely if you're young, it could be a cyst, no question. But, I think it's really important for women to know what their breast tissue feels like. 50% of women find their own cancers. And a lot of people, I can't tell you the number of times someone was saying, I don't usually examine myself, but over there, and there was that there are people kind of know when something is off and different. And so I think it's really important to just, not make a giant deal over it. Even if you kind of like go up and down your breast, just like up and down like this and all around, it doesn't have to be like really when you once a month in the shower, every once in a while, but just know what your breast feels like. Because if you find something that's new, you had a mammogram or sonogram or anything else, and if you get a mammogram and you don't tell them that you feel something, they could miss it, because you can miss something on mammogram. If your breast tissue, if the breast tumor is the same density as the tissue around it, you won't see it with a mammogram, and you probably won't see it with ultrasound either.
Another question that we get too is around dense breasts, and hearing that now, there's recommendations for women with dense breasts to get MRIs. And I think the definition of, women are now being told in their regular mammogram result letters that they have dense breasts. which can be a category C or a D. They don't tell you which. So just guidance for people if they've been told they have dense breasts and how that relates to additional MRI screening.
Well, it's very important to know that 50% of women have dense breast tissue. So don't get too excited when they say you have dense breast tissue. If you have the highest, so if you have what we call BI-RADS D or extremely dense breast tissue, that you're in a category where it may be a little more difficult to see or find a cancer. And if you have other risk factors, it could very well be that you should have a different kind of screen. That's one of the things that we look at when we do the screening in the wisdom study. So anyway, I think that, I think it's unfortunate that we take this information that really scares people and, that we tell people that they have to get an MRI or they have to get an ultrasound. And ultrasounds, it's not really clear how much benefit is generated by doing screening ultrasounds. That's often something that's recommended, when in fact, that's not necessarily the right thing to do. If you really have high-risk disease, or you're at high risk for getting breast cancer, you should get screened with MRI, because an ultrasound is not going to be anywhere near as effective, because we know that. A contrast-based test is what's important. If you have dense breast tissue, chances are that it's hard for you to see the tumor above the background. And ultrasound and mammograms look at the difference, are looking for differences in density. So if your tumor is the same density as your breast, and the breast and everything's dense, the MRI is going to show it, because MRI works by looking at blood flow. It has nothing to do with the density. So it's looking in a completely different way. So we strongly recommend that you know your risk. And of course, everybody here knows they can just join wisdom. That's how they can sort it out. We just need to do a better job, certainly than what we've been doing with the way we screen everybody the same.
So I think it's important to note that on those letters, it will say you have dense breasts, even if you have the two categories. And really the most important is for that small number of women with extremely dense breasts to get, to consider supplemental imaging if the additional risk factors also lend to being at higher risk. So I think it's fair to ask for a copy of your mammogram report. We always ask for that because we need that specific density score in the wisdom study to create your personalized risk profile. So it's, you should get access to your mammogram report and see, is it a density C or is it a density D? And again, over half of women have one of those two categories. So
That's right.
one other question that someone just asked in the chat was, does breast reduction surgery reduce the risk of breast cancer?
Well, it turns out that it does, actually. I guess it's not that surprising. If you do a mastectomy, you're taking out 95% of the breast tissue. You're not getting every last cell out. And that reduces your breast cancer chances by like 95%. If you do a breast reduction, a lot of people think that some of the data suggests that it probably cuts your risk in half. So everyone who's been dying to have a breast reduction here, and if you're at high risk, that is actually a good strategy.
One other question is around AI breast screening. And do you think AI breast screening is helpful for dense breasts for menopausal women? I think there are now some radiology centers that are offering an add-on service, a cost for AI. And this was a question someone had after the last forum of, is it worth adding that on? Is it ready for prime time?
So it's not clear at this point. I mean, I believe that within a few, I really do believe that in a very few months, you know, maybe 10 months or so, that there will start to be these tools out there that you can really look at. I do think that the mammographic AI is going to add something. I think part of the reason why I've wanted to study it a little bit more first is because we really don't know if it's finding the same things that we find on using the polygenic risk or a regular risk source, or there's something really different. And so, or how do we interpret it? Maybe they're actually additive and we should be looking differently. So one of the things that we're trying to do is we're trying to figure out what are the contributions that each of these things plays in contributing to risk. And as you think about risk, how does the mammographic AI fit in? How does the polygenic risks fit in? How does, you know, the regular standard tools, or once you're using risk, do we forget about family history, everything else? What happens? Does it modify the risk once you know your mutation? There's so little that we know because each group does their own thing and they don't do the integrated models, which I think are really important. So that's one of the reasons why we're going to bring it in a way that we can really look at every, you know, look across all of the risk factors. We might have something that's really a powerful risk predictor. I mean, we hope so.
Yeah. I would also say we just got a small grant to start to look at some of the bias in AI as well. And that's something to consider, as some of these models or algorithms may not quite be ready to be applicable to the broad population. The models may have been developed in not a representative cohort. So that's one thing that we're hoping to do too, really to make sure that when the information is out there, that it's applicable and can be tailored to everyone. So yeah, I think there are some imaging centers that are offering it. The participant who had contacted us said that they were offering it for $40 to add on AI. So yeah, it's there's lots coming out
I mean,
to the consumers.
Like everyone was asked to add on or pay for Tomo. I don't think Tomo adds that much. If you're really at high risk, you need to get a contrast-based image. You need to get IV contrast mammography or MRI. And I think people wind up paying for things that they don't necessarily need. That's why I like to try and do things on study till we can really sort it out.
Mhm. Yeah.
But we, as part of wisdom, within a year or so, we'll be adding in for sure, the mammographic AI as to determine short-term and long-term risk in our populations.
So as we come up on the top of the hour, I just want to see if anyone has any additional questions that they want to ask. In the chat, there were a couple questions about the next meeting, which will be moved up a week to May 20th due to the Memorial Day holiday. For that session, it'll be at the same time, just moved up a week. And so we have Lisa Madalinsky, who is one of our genetic counselors and leads on the study. She's at UC San Diego. She's presented before, but she will actually do a deeper dive into some of the risk models that Laura spoke about and sort of what's out there, you know, comparing some of the tools and the products that are out there. Laura mentioned the Myriad MyRisk and Tyrer-Cuzick and the Gale model, and there are lots of models that are out there. There's lots of similarities, but there's a lot of differences too in terms of those models. So she'll be able to walk us through sort of what they entail, why we chose what we chose, and you know, really again, the goal of trying to put together a comprehensive risk assessment based on data that's representative and can be evidence generating. Importantly, that we're continuing to learn and we're continuing to improve and we're continuing to test new models and refine our approach to make sure that we are tailoring our risk assessments as best we can. Yes, so one other question just came in. So going back to the discussion around tamoxifen as a preventative treatment in premenopausal women, what are the long and short-term side effects that patients should be aware of tamoxifen in premenopausal women?
So for prevention, I would use 5 milligrams. It's a quarter of the dose. So we call it baby tam, right? So that has been shown. The studies are not as big as the 7,000 women apiece, but it doesn't cause endometrial buildup. It doesn't increase clot risk. There's a very small risk of getting sort of a minor clot in your that can get in your legs and then go to your lungs. That's probably the thing that would be the most concerning, but these are usually small clots and they're not something that really pose a lot of risk to people. So I think that is actually really important to know. And the kinds of things that we look for is buildup of the endometrial lining or things like that we don't see with these low doses of tamoxifen. And there've been a number of sophisticated studies really looking at how people feel on the drug. And when people were placebo bound to try and figure out if it was working, and so we did it to try and reduce density in young women. This was a study in Sweden. They really looked at 1 milligram, 2.5 milligrams, 5 milligrams, 10 milligrams, 15 milligrams, and 20 milligrams. And it turned out that there was a big drop in side effects that are reported from 20 down to 5, but after 5, it didn't really make much difference. The smallest amount that's made is 10 milligrams, so you can either take it every other day or half of it once a day. And so I would say that, there isn't really a long-term side effect, and you wouldn't take it forever. And I think, as someone brought up the other day, I think Fumi Alapane brought it up, is the one thing you don't want to do is you don't want to get pregnant when you're on tamoxifen. So if you're thinking about having kids, prevention's not an emergency. It's something that you can do, but you don't have to do, right? So you can think about, well, when do I want to have my children? Because you want to offset also by having your children earlier, you also reduce your risk more. So there's lots of things you can do. You can take it and say, okay, why don't you why don't you think about first finding out if it bothers you, or if you're trying to decide what to do with your family, maybe you want to have your family now, wait till you finish having your kids and have finished breastfeeding and then do this, because it's not necessarily an emergency for you to start at 30 versus 35. But you do know that you can reduce the density of the breast tissue, which that's another surrogate for showing when it's working. And I think one of the problems that sort of led to people not wanting to use it is some of the side effects, which I think that baby tam really makes a big difference for. And the second thing is, getting feedback. If you took a blood pressure lowering medication, your blood pressure would go down. If you took a cholesterol drug, your cholesterol would go down. So it's very disheartening to be put on something and you have no idea if it's working. So there are now ways that you can look at the density and see if it's changed, and that's predictive of whether it's going to help you. So these are all good things. Even treating ductal carcinoma in situ or DCIS, we're actually using these different kinds of endocrine treatments up front to see if we can reduce people's risk by following what happens on their MRI. And so building tools to show, well, what's another way of assessing my risk of the MRI? And, can I actually show that I'm getting rid of it? And I think that's very compelling for people. So these are the ways in which we're trying to fix it. Obviously, we're trying to think about what else we can do to lower risk as well,
And Laura, you gave a couple of examples last week of sort of analogies of taking a statin, or I think you also gave another one, like if you live in a hurricane zone, just sort of thinking about it in that type of way. You're trying to build a better infrastructure.
Right. I mean, I think you want to also think about, well, what can I do to reduce my risk as much as possible?
if I'm living in prime hurricane zone, like build right on the water. If you live on the water, at least build 10, FEMA makes you put in a hurricane glass and build up 12 feet from the water. Or, if you're in a flood zone, think about putting things in. If you're living at the side of the hill, don't get a house that doesn't shore up and isn't made accommodations for where you are. It's just being smart and trying to think about, well, what can I do to gather all the information I have and do my best to reduce my risk. And so what I want to do is I want to have more options for people, not fewer. And things that are both lifestyle risk, getting rid of chemicals and, that are in the environment. There's, keeping diet and weight in control, or at least identifying that if you are, if there are some things that you can do to lower your risk, that you can start working on it. And if you need help, then you can get help too. I mean, saying to someone, well, eat right and lose weight if you're overweight, it's not so simple, right?
Mhm.
So,
Yeah.
what are the things that we can do to really help people?
Well, and I
those are-
think,
yeah,
and one of the takeaways from the Walter Willett discussion too was, it's not if you drink heavily, the impact can go away. If you change your behaviors, the risk can go away if it's reversible, I guess, is a better way to put it. So
yes.
it's not too late to create a new regimen and to get on track. And
If you're drinking too much wine and you say, well, I'm drinking like 1 to 2 glasses of wine, or having drinks like 10 a week, cut it back to like 2 or 3 a week. If you're on hormone replacement therapy with progesterone, get rid of the progesterone. That for sure is the culprit in that. So what are the things that you can do to think about, reducing that risk? And when you make those changes, it's not like once you've done it, your risk is up forever. That's not true. I mean, if you have mutation, you can't undo that. But, and, there's certain things you can't do. You can't uninherit your families and your genes, but there are things you can do to mitigate that risk, and there are things you can do to reduce it. And, a lot of people say, well, I don't like taking medicines, but, really significantly reducing your risk if the long-term sequelae are low, you really want to be able to do that.
yeah. Okay, well, we are up on our hour. Thank you, Laura. And we will continue this discussion next month and dig in a little bit more to some of the risk models and the risk factors and the differences between them. A couple of them were mentioned earlier today, so should be a good opportunity to dive in a little deeper. But I think the overall resounding theme is that, we really do need further research and to generate the evidence to be able to really identify personalized risk factors and find those people at risk so we can reduce that risk and allow people to have the information they need to make decisions about their health. Age-based screening is not sufficient. And so doing comprehensive risk assessment and giving people information at a younger age is what we need. So Wisdom, as Laura mentioned, is now open to women ages 30 and above, and we would encourage you to share Wisdom with anyone you know who wants to learn their risk and get a personalized risk assessment. Again, all of it is provided through the study at no cost. And so it's a great resource to be able to learn about your own risk and be able to take action if needed. So there is a short survey in the chat if you guys want to give us some feedback, also give us some ideas for future forums, but we'll look forward to seeing you next month on May the 20th. Thanks so much for joining, everyone. Thank you, Laura.
Thanks so much for joining. I hope that was helpful.
Yep. Thank you, Laura.
Okay, thank you.
All right. Have a good evening, everyone.
Good night.
Bye.